Welcome you, sir. Next, we have a topic, Approach to Ophthalmoplegia by Dr. Sujithra. She is a professor and consultant in oculoplasty from Amrita Institute.
Thyroid eye disease is a common cause of proptosis and ophthalmoplegia. It is an autoimmune disease, and there is deposition of glycosaminoglycans in the orbital tissue, which causes proptosis and soft tissue involvement. Here, the cause for loss of vision is due to corneal involvement or compressive optic neuropathy. So we need not do imaging all the time, but when the diagnosis is in suspicion, then we have to do imaging. Or if we are planning for surgical intervention, then again we need to do imaging. Can do CT scan if we are planning orbital decompression, and if we are suspecting optic nerve compression, then it is better to do MRI. Coming to treatment, always we have to control the dysthyroid state, then we have to stop smoking. Okay, that aggravates the thyroid eye disease, and the high dose pulsed intravenous methylprednisolone, it arrests the progression of orbitopathy, and there are reports supporting the effect of selenium on slowing the progression of thyroid eye disease. And coming to radiation treatment, it is effective in controlling the inflammatory phase, that too in the moderate stage. Okay. And another side effect of this radiation therapy is the effect is not immediate. There is time lag for about few weeks. So we have to start steroids along with radiation. Coming to surgical treatment, that is orbital decompression is done to reduce the proptosis, and if there is optic nerve compression, then that is an immediate indication for surgical decompression. Here, if we want optic nerve decompression, then we have to do posterior decompression, that we have to remove the posterior wall of posterior medial wall. And if it is only to reduce the proptosis, anterior decompression is also enough. So this patient presented with acute thyroid orbitopathy with compressive optic neuropathy. There is field defect and vision decrease in vision. He was treated with intravenous IV methylprednisolone, and we can see the improvement in visual fields and also the inflammatory reaction. This patient presented with, again, acute optic nerve compression, that too bilateral optic nerve compression and severe proptosis, and in her right eye the vision was hand movements to PL present, and there was corneal ulcer, and that too fungal corneal ulcer. She was started on IV methylprednisolone, and then immediate orbital decompression was done, and we can see the picture before treatment and after treatment. Coming to idiopathic orbital inflammatory tumor, that is previously it was called orbital pseudotumor. It can affect any tissue in the orbit. Here, one important differentiating feature from thyroid orbitopathy is in imaging, the tendon is also involved, and any ocular tissue, any of the orbital tissue can be involved. And here the diagnosis is by diagnosis. This is diagnosis of exclusion. So we have to do imaging and biopsy to exclude other causes of orbitopathy, and it responds very well to steroids. And here they require long-term immunosuppression. That is another differentiating feature. This vaginous granulomatosis also can cause orbitopathy. It can present as ophthalmoplegia, optic nerve compression. If the patient is already on immunosuppression, we need to step up the dose. If it is newly diagnosed case, we have to immediately start on immunosuppression, steroids and non-steroidal immunosuppressive agent, and slowly we have to taper steroids and stop and continue the non-steroidal immunosuppressive agents. Here we can see the eye before treatment and after treatment, and there is significant improvement in field defect. And coming to the one important cause of ocular emergency, that is orbital cellulitis. Here this patient developed orbital cellulitis following an insect bite. He presented to us with severe eye pain, headache, and vision was no PL. And we did CT scan to rule out sinus infection, and MRI and MRV was done, which showed cavernous sinus thrombosis. So he was admitted, started on intravenous antibiotics and anticoagulants. Here we have to give broad spectrum antibiotics, that we started vancomycin and piptas to cover gram negative, gram positive bacilli, and MRSA also we have to cover. If we suspect dental infection, then we need to start on Metrogel also. And we need to closely follow up the patient. And whenever we suspect any orbital cellulitis, immediately we have to start IV antibiotics. Then we can do all the other investigations. So here the time is very important. We need not allow any orbital cellulitis patient to reach no PL stage. And when any immunocompromised patient present with ophthalmoplegia or decrease in vision, we have to suspect fungal infection of sinus. And if there is, if the fungal infection is confirmed, then we need to start on antifungal agents depending on the fungus. Okay, either liposomal amphotericin or voriconazole we can start. If there is involvement of sphenoid sinus or posterior ethmoidal sinus, it can present as optic neuropathy. Sometimes you can get fungal infection and vaginous granulomatosis. Here this patient was confirmed case of fungal sinusitis, but he was not responding to the usual antifungal agents. So when we did repeat biopsy and imaging, we could find that there is vaginous granulomatosis. So he was started on immunosuppressive agent along with antifungals. Then antifungals was slowly stopped and he was continued on immunosuppressive agents. So whenever the response to treatment is not as expected, we need to reevaluate and confirm our diagnosis and change or modify our management. Coming to corticocavernous fistula, it can also present as ophthalmoplegia. Broadly, it is classified into high flow and low flow. And high flow fistulas are common in young individuals, and that too following trauma. Low flow fistulas occurs in old age, and it occurs spontaneously. And treatment is required for high flow fistula. And in imaging, the classical feature is enlargement of the superior ophthalmic vein that you can see in the axial view, and also in the coronal view, the enlarged vein you can see under the superior rectus and LPS complex. Lymphoma, it causes homogeneous enhancing lesion. Here treatment is chemotherapy and biopsy confirms the diagnosis. Whenever any patient with systemic malignancy presents with ophthalmoplegia, have to suspect orbital metastasis, and imaging confirms the diagnosis. And we have to do systemic evaluation to look for other metastasis. Thank you.